I will talk about uncontrolled DCD, and the question is still an issue. My answer, it will be yes. I think I could finish my talk here, but anyway, I will try to convince you that yes, it's still an issue. I am coming from Madrid. This is a special place in Madrid because Real Madrid used for their victories, but this year was a disaster. So I think next year it will be much better. Well, I think all donors are important. DVDs, DCD, uncontrolled, control, euthanasia, culture positive, hepatitis C. So I will make a definition of uncontrolled DCD type 2. As you know, the Maastricht classification in two types, uncontrolled and control. And type 2 is a patient dead at the hospital after unsuccessful advanced cardiopulmonary resuscitation maneuver. And you can divide it in 2A or B. Almost all of them are type 2A. So you know that it must be a cardiac arrest, a witness cardiac arrest at home or in the street. And we have many situations that you can find a person that has a cardiac arrest outside in a normal life. In our experience, how do uncontrolled DCD die? Well, most of them is a sudden cardiac arrest, but we have patients with electrocution, aortic dissection, or even cerebral trauma, but always they have to be witness cardiac arrest. In Madrid, we have an advanced life support unit that they are working very well, and they know that if they have a cardiac arrest, they have to think and they have to begin a protocol that I will show you. But it's very important to have a legal status. So we need a law that confirms a cardiac arrest and is defined as a non-beating heart and non-spontaneous breathing in a patient after 5 minutes of cardiac arrest, after 30 minutes of advanced cardiopulmonary resuscitation in a non-hypothermic patient and non-intoxicated patient. Well, as you maybe know, we have the highest rate of multi-organ donor per million population. Last year, it was 48, and in the last 5 years, Spain experienced the highest increase in donation. And when we compare with other countries, last year were the highest rate of per million population. And when we are talking about DCDs, donor in Spain, we can say that when we began to think about these donors, we did more than 5,600 DCD donors. It represents more than 1,100 transplants per year from DCDs donors. So right now, last year, it represents the DCD, the 28% of all donors, and in numbers were 629 DCD donors. When we are talking about lung transplant activity in Spain, you can see here in the last column that last year we did 369 lung transplants, most of them from DBD donors, but you can see here that 64 were from DCD, and the numbers DCD2 were few, but the last year 7,488 and 2 lung transplant from DCD to donors. But the aim of this program of DC2 uncontrolled donors is, it was the transplant kidneys. And you can see here that 1,892 kidneys were transplanted from DCD uncontrolled donors, 170 livers, and lung, almost 100 lung transplants were from DCD uncontrolled donors. And this is the lung transplant DCD activity in Spain. In total, at last year, was 226 lung transplant. And for example, in our hospital, we did 52 in total uncontrolled donors, lung transplants, and 21 type 3 in total, 73 lung transplants from DCD donors. I just want to resume our protocol. The advanced life support, they will be in less than 15 minutes in the place where the cardiac arrest was. They will try to recover the patient, even transporting to the hospital in Madrid, where all the cardiac arrests go, is San Carlos in Madrid at the emergency room. And they have to obtain the consent, the judge consent, and the family consent. After that, they will use ECMO support, but just for abdominal organs. And kidney is the most important organ at that time. But for lungs, we use topical cooling, and we preserve the lungs with Perfadex and donor and blood from the donor. We transport the lungs to our hospital, and we do the transplant. Well, this is an example 2 weeks ago. We had a donor, 20 years old, female, obese. The cause of death was sudden cardiac arrest, pulmonary embolism, or cardiac arrhythmia. The advanced life support came 5 minutes later, and they arrived 1 hour later to the hospital. Topical cooling 20 minutes later, and PA perfusion at 9 p.m. So from 4 to 5 to 9 was 5 hours of transport. The evaluation, the lungs look very good, PF 400, but the surprise was that it was a total embolism. So we decided to do EVLP in this case, and 150 minutes of ex vivo evaluation. And as you can see here, microscopically collapse tests were normal, and the hemodynamics were also normal. No loss of solution, as you can see here, and PA, PVR, and flow was normal, and also the respiratory pressure. So we decided to go on. This is our director of the EVLP, Lucas Hoyos. The implantation was in a patient 60 years old, fibrosis, pulmonary hypertension. So we decided to do ECMO during the operation. Good surgery, good surgeons, Silvana Crowley and Jose Luis Campo. And after that, the total ischemic time was 14 hours for the second lung, 150 minutes ex vivo, 180 minutes ECMO, and this was the first postoperative chest X-ray at 6 hours, and 24 hours after veno-venous ECMO, and 4 days later he was extubated, and he's doing very well. So this is our experience in this period of time, and you can see here that the potential donors were almost 100 uncontrolled donors, and we did 52 lung transplants. It represents 5% of lung transplant in our hospital. I think 5% is important because we need donors, so I think we will continue, of course, with this type of donors. The incidence of PGD grade 3, it was evaluated in our hospital, and this is Daniel Valdivia. He did a good effort to do this, and the trend is to have a higher PGD in uncontrolled, but it was not significant when we compare with brain death donors. So we think ex vivo evaluation is the answer. So we do more ex vivo evaluation in these patients. We have experience with the OCS. We were in the international clinical trial, but now we are working with VivoLine, and we are happy with this system. So this is the total number of our patients after lung transplant. The mortality 30-day was 16%, but this is historical. Now with the use of ECMO in the post-operative period, the mortality is less. And when the survival is conditional for the 1 year, the results are very good. So we compare the cohort of brain dead donors and uncontrolled, and you can see here there is no significance in survival. We published several times our experience in some publications after 20 years of experience with these uncontrolled non-heart-beating donors. And as Dr. Insis said, it was in this publication that the first case reported was by Steen in 2001, and Steen is a very good friend, and we continue his experience, and we did the 17 cases after that experience of Steen. And this is a very recent publication from another group in Spain, from Santander, and the results with this kind of donors were very good. As you can see here, the 1 month survival was 100%, and 1 year and 5 year survival 87.5% after using this type of donors. And now this year, it will be published, this expanding the horizons, uncontrolled donors after circulatory death for lung transplantation. It will be the first comparison with brain death donors and this type of donors. And from Toronto, this is a very interesting paper using the CPAP and prono preservation that it will be very interesting to know in the future. So our conclusion is that controlled DCD type 3 is the future in lung transplantation, but uncontrolled DCD2 is valid donors in lung transplantation. And of course, ex vivo validation, preservation, and recovery, it's advisable. So my answer to this question, it will be yes. I have to say that we have a really very good team working in lung transplantation, and I am very happy to be part of this team. And if you go to Spain, don't forget to have tapas. Thank you very much.